And so I think we can start. So I've been tasked to talk about neurotransmitters and neuromodulators as part of the basic neurosciences. So from my reading, neurotransmitters, they date back to the days of this guy. I think his name is Otto Louis. He's the first person who identified acetylcholine. So what he did was he took two hearts of a frog, one that was innervated by a functional vagus nerve, then the other one was not. Then he put a syringe with normal saline in each. So he then activated the vagus nerve for the frog heart that was still activated. Then that meant it then released acetylcholine, which suppressed cardiac activity. Then he took the saline from from that heart that was innervated that now had acetylcholine, then put it in the non-innervated heart. Then he also noticed that there was suppression. So from then he then coined acetylcholine as something called Vagastov, which was the neurotransmitter being released by the vagus nerve. But that's what we later knew as acetylcholine. So basically, a neurotransmitter is a chemical substance that is released um, at the end of a nerve fiber when you have an, an like an action potential, a nerve impulse that would have been propagated across either a synapse or uh, the synapse being nerve to nerve or any other form of synapse. So, in simpler terms, it's a chemical that allows for communication within within the body and basically within the nervous system. Right. So, a neurotransmitter and a neuromodulator are not really the same. Neurotransmitter is the chemical substance with that direct effect, but a neuromodulator it's now a chemical substance which is going to be released by neurons, and it has no direct effect on its own. But what it does, it modifies the effect of a neurotransmitter. So, neurotransmitter is the one with the direct effect. The neuromodulator is now the chemical substance that's being released that is going to have um, more of a modifying action on your neurotransmitters. I think a classic example would be your adenosine triphosphate. The nitric oxide um is both a neuromodulator and a neurotransmitter, right? So there are various ways of classifying neurotransmitters. We can either classify them in terms of molecular size, where you have small molecule neurotransmitters, then large molecule neurotransmitters. For the small molecule neurotransmitters, you have those that are just amino acids. When we look at the biosynthesis of most of these neurotransmitters, you're going to realize that some of them um, made from amino acids. So you have those that are just simple amino acids, for example, your glutamate, GABA, and glycine. We'll talk about them towards the end. Then you have your monoamines and your catecholamines. Catecholamines being the ones that you find from the medulla of the adrenal gland. Then the monoamines, the most important one would be acetylcholine, which we'll talk about at length. Then for the large molecule neurotransmitters, they're basically your neuropeptides, and the most important ones would be your substance P and your vasopressin. Then the other way of classifying your neurotransmitters would be to classify them as excitatory and inhibitory neurotransmitters. So you have excitatory, then you have inhibitory. The excitatory ones are basically your glutamate, acetylcholine, dopamine, but the main inhibitory neurotransmitters will be your GABA and glycine. Dopamine has both an inhibitory and an excitatory function. On it just depends on your receptor that you are using, right? Then in terms of biosynthesis of your neurotransmitters rather, they basically come from amino acids. So for example, you have glutamate. So you have alpha ketoglutarate, then you convert that to glutamate. Then from glutamate you can actually get GABA. So the reason why I just put this was to emphasize the fact that some neurotransmitters are going to come from amino acids. Then you have other neurotransmitters that are going to come from acetyl-CoA. And the classic example will be your acetylcholine, right? So you get acetyl-CoA um, from your pyruvate pathway. That combining with choline, they'll create acetylcholine. The acetylcholine, in terms of being degraded, it will be degraded by an enzyme called acetylcholinesterase. For you to have the reaction between acetyl-CoA and choline, you need choline acetyltransferase being the enzyme, right? Then so we've said that most of the neurotransmitters are going to come from amino acids. Then you have those that are coming from acetyl-CoA, the most important one being your acetylcholine. Then when you then have the neurotransmitter, for it to function, it's going to need a receptor. So there are two basic types of receptors that are going to work. And these two types of receptors, they are what we call ligand-gated channels. Then there are those that are called G protein coupled receptors, which are basically your serpentine metabotropic receptors, the ones that span the cell membrane about 7 times. So the ligand-gated channels, the inotropic channels, are basically the ones that allow for influx of positive ions like sodium and potassium. Your metabotropic are going to be either G stimulatory or G GQ or G inhibitory. The GQ pathway is the one that uses phospholipase C, right? So there's a way that we used to remember when we were in part one. So if you look at the metabotropic receptors, the mnemonic that we used to use was kiss, kick, sick, sec, right? So the Q, I, and S were just basically referring to being G, Q, or GI, or G stimulatory. That means the first five, which is your alpha 1 and alpha 2, then beta 1, beta 2, beta 3, these are going to be receptors for your catecholamines, basically your norepinephrine and epinephrine. Right? So alpha 1, alpha 2, beta 1, beta 2, beta 3. The kick, it's your muscarinic receptors, which are going to be part of the receptors we'll talk about for acetylcholine. So that's M1, M2, M3. Though they go all the way up to M5. Then your S1 and S2 and sorry, your D1 and D2 receptors. D1 is G stimulatory, D2 is G inhibitory, which reemphasizes the point where we said dopamine can either be stimulatory or inhibitory, depending on the receptor it will use. For example, when you look at your nigrostriatal pathways in the basal ganglia, right? Then histamine, there is a Q and an S. So H1 mostly in the respiratory tract, that's GQ. Then H2 is the one that you now find in the stomach. So that will be G stimulatory. Then V1 and V2 are receptors for vasopressin. So I just thought of putting this because this is how I've always remembered receptors and even linking it to the pharmacology. So it's kiss, kick, sec, sick, right? So the first three, it's alpha, beta, then the M, then you go back in alphabet. So you start with the D, then you go to the H, then you go to the V, right? Then in terms of the actual neurotransmitters now, Acetylcholine, remember we said this was the first neurotransmitter that was actually discovered, right, in 1936 through that experiment, which has become, I think it's one of the main experiments that are done in physiology, using a frog heart, right? So this neurotransmitter is responsible for most of the stimulation of muscles, including those that you find in the gastrointestinal tract. And also remember, you have your neuromuscular junction, right? So there are going to be receptor types. So remember, I said there is your muscarinic receptor. Then there's going to be your nicotinic. Maybe I can come to this. So there is your nicotinic, then there is going to be your muscarinic. Your muscarinic receptors are basically going to be G protein coupled um, receptors. So there is M1, M2, M3. And remember, we said some of them are going to be G inhibitory. The other ones are going to be coupled to the GQ for the phospholipase pathway. Then the nicotinic receptors, the ones that you find at all autonomic ganglia and your neuromuscular junctions, these are going to be uh, ion channels, which are going to allow for influx of positive ions that cause depolarization. Hence, you get excitation. So basically, you want to stimulate towards threshold, then you get an action potential, which is what we were taught for the last time, right? Then for for your for your muscarinic receptors, you're going to have binding of your acetylcholine on the outside, and when it binds on the outside, it causes a configuration, a configurational change on the inside, and there's going to be efflux of potassium. Then you get uh, so when you get efflux of potassium, it's going to be what have I done? It's going to be it's going to cause hyperpolarization, and then you get inhibition. That's how acetylcholine will inhibit the heart. But in terms of excitation, your potassium channels are going to close. And if the potassium channels close, there's going to be depolarization. And remember, there's those sodium potassium ATPases. So basically, if it's not working, you're then going to have the other channel which transports sodium and calcium, allowing for influx of those positive ions. Then that causes your smooth muscles to contract, especially in the gastrointestinal tract, right? Then this is just for where you find the for the receptors. So the reason why the mnemonic had M1, M2, M3 was that M1, M4, and M5 will actually be in the CNS. M2 is what's specific for the heart. Then M3 is what's specific for the smooth muscle. So we used to say M1 is in the head, M2 is in the thorax, M3 is in the abdomen. It's basically the smooth muscle, or the visceral muscle of the GI tract, right? Then this is also speaking about where you find your acetylcholine in terms of function. So neuromuscular junction, then your preganglionic, sympathetic and parasympathetic neurons, it's all going to be what? To be acetylcholine. But what then differs will now be the postganglionic, because remember, for postganglionic, for sympathetic, you're then going to have your catecholamines. Then there are exceptions. We used to remember saying in Ganong there are three exceptions to that, where the ones that go to the sweat glands and the piloerector muscles, as well as part of the blood vessels, you're going to have acetylcholine, even though it's going to be postganglionic sympathetic. So it's not all postganglionic sympathetic um, fibers that release your catecholamines. Some of them will also release what? Will also release acetylcholine, right? Then in terms of clinical correlates, um, when you have, so there are clinical correlates that are more important. For example, there is myasthenia gravis, where you get autoimmune destruction of your acetylcholine receptors at the neuromuscular junction. And this can now be linked to other things like thymomas and the like. Then if you get severe damage to your cholinergic pathways in the central nervous system, it can be a cause of Alzheimer's disease, though the actual causes for Alzheimer's disease are not clearly understood, right? But it is thought that one of the causes of Alzheimer's disease would be damage to the cholinergic pathways, right? And if you look at those cholinergic pathways, they are concentrated in regions which have cognitive functions as well as memory. So that's why it is thought that Alzheimer's disease is one of the end results of what? Of damage to the cholinergic pathway, right? Then there's also the issue of botulinum and Cure. So botulinum, it basically works by preventing vesicles in the axon ending from releasing acetylcholine. And if you don't release the acetylcholine, you're then going to cause paralysis at the neuromuscular junction, right? Then Cure also works by blocking your receptor sites on the motor end plate, basically where you have the muscle end on the neuromuscular junction. So that's basically your acetylcholine. Then the main um, excitatory neurotransmitter is glutamate, and that's responsible for 75% of the excitatory transmission that you find in the CNS. So for most of the pathways that we do, so be it in the eye, be it in the central nervous system itself, you talk about glutamate as the main neurotransmitter, and there are three basic um, receptors that we talk about for glutamate. So there is AMPA, then there is kinase, then there is the NMDA receptors. The NMDA receptors being the ones that are more important. So these, they allow sodium and calcium to go into um, the cell. And if the sodium and calcium go into the cell, you're going to cause excitation or basically depolarization, hence it becomes excitatory. Then it allows for potassium to go in the opposite direction, right? Then GABA is the main inhibitory neurotransmitter. So there is GABA, then there's glycine. Glycine will be more for the spinal cord, but the main inhibitory neurotransmitter is GABA. And GABA has GABA A, GABA B, and GABA C receptors. The way we remembered it was GABA A and GABA C. They basically are going to allow for chloride influx into a cell, and that's basically inhibitory. Then GABA C receptors were mostly found in the eye, so it's inhibitory to the eye. Then GABA A, it's inhibitory everywhere else. Right? So those are ionotropic receptors, the A and the C. Right? They allow for chloride influx into a cell. Then GABA B on the other end, GABA B receptors on the other end, they are G protein coupled receptors. So these are also going to be working the same way as your all the other metabotropic receptors, just that they are G inhibitory. So what they do is they allow for an increase in conductance to potassium, right? And when that happens, you also then inhibit influx of calcium. So that leads to hyperpolarization. So instead of actually depolarizing and moving towards threshold, you're going to be moving away and causing hyperpolarization. And basically that causes what are called IPSPs, right? Then in terms of pharmacology, I'm sure you guys are aware of benzodiazepines and barbiturates. So benzodiazepines are GABA A receptor antagonists, and we basically use these as mostly as convulsants, and they also have sedative properties. So how they are working is basically if you're an agonist to a GABA A, which we said increases influx of chloride, you're then going to promote um, inhibition, right? The same can be said for barbiturates. They're also GABA A um, agonists. Just that your barbiturates are the ones like phenobarb, thiopental. Then your benzodiazepines are the ones that basically end in um, AM, right? Or your PAMs. So diazepam, lorazepam, then midazolam as well. It's a common benzodiazepine, right? Then the other inhibitory neurotransmitter, we said it's glycine. So glycine is the main inhibitor neurotransmitter that you find in your spinal cord. But it also has certain regions where it's going to be excitatory, right? It binds to NMDA receptors, and when it does that, it makes them more sensitive to glutamate. So in that regard, it will be almost like a neuromodulator. That's how it ends up also being what? Excitatory. But in terms of how its main function comes about, which is inhibition, the receptor is a chloride channel as well. So what it does is it also increases chloride conductance. And if it increases chloride conductance, you end up having hyperpolarization, right? So glycine, the main function for glycine will actually be inhibitory, and it does that through chloride channels, which is almost the same as your GABA A and GABA C receptors, which also increase conductance of chloride, right? Then the other important neurotransmitters, your catecholamines. So catecholamines, it's your noradrenaline, adrenaline, and dopamine, and these come from the medulla of your adrenal gland, and they can also be released from nerve endings. I think that's where the point comes where they say these can be regarded as neurotransmitters, or they can also be regarded as hormones, right? So um the neurons that produce adrenaline are your adrenergic, then those that produce the noradrenaline will become your noradrenergic neurons, right? So these ones, in terms of synthesis, you need to remember that the rate limiting step is the conversion of tyrosine to dopa. And this used to be a common MCQ in medical school, right? Then the pathway then goes all the way down to epinephrine. But in terms of things like pharmacology and psychiatry, as far as they're concerned, there are certain enzymes that allow for degradation of your catecholamines. So there is MAO and then there is COMT, right? So basically, what COMT does is it, from your norepinephrine, you can go to your normatinephrine using COMT. Maybe I can use the other diagram. Okay, yeah. So you can have conversion of these catecholamines into various molecules that can be found in urine. That's when you then measure these molecules in urine, and that will be vinyl mandelic acid, which will be one of the final common end products for degradation of catecholamines using MAO or COMT. So MAO is your monoamine oxidase, then COMT is your catechol or methyl transferase, right? And then in terms of receptors, remember when we said kiss, kick, sick, cess? So the first two, that was alpha 1, alpha 2. So alpha 1, that's the Q, so it's GQ. Alpha 2, it's G inhibitory. Then the beta receptors are going to be stimulatory, so G stimulatory, right? Then when you look at the two, noradrenaline will have a greater affinity for your alpha receptors. Then adrenaline will have a greater affinity for the beta receptors. But it doesn't mean your adrenaline will not attach on your alpha receptors. It will also work on those. So they are all G protein coupled metabotropic receptors, right? So your beta receptors, they're G stimulatory. Then your alpha, there's one that's GQ, that's alpha 1. Then alpha 2 is G inhibitory. So you just think about at any instance where you want, for example, in pharmacology, where you want your noradrenaline to have an inhibitory function, there's likely going to be a G or rather an alpha 2 receptor, which is G inhibitory. That's how we used to link it, right? Then, okay, it's not moving now. All right. So this is just talking about the receptors that I was trying to tell you. So alpha 2, we say they're G inhibitory. Then alpha 1 is going to be what? To be GQ. So it works through your phospholipase pathway. You increase IP3 and DAG. Then you end up activating protein kinase C, which is different from the G stimulatory pathway, where you stimulate another kinase, which will be protein kinase A, right? Then, in terms of inhibition of release of your catecholamines, the presynaptic receptor will have an alpha 2 receptor. So when you have enough catecholamines rather, you're then going to have them binding back on the presynaptic terminal where you find your alpha 2 receptors, which are G inhibitory. Then so there are more of autoreceptors to limit the release of those catecholamines, right? So you find them on nerve terminals mostly. They are for them as autoreceptors. Then also you find them in your pancreatic islet cells, right? Your beta receptors, you find them in the heart, as well as in your kidneys, right? Beta 2, I think it's important to remember for your respiratory tract when you do the pharmacology of asthma. Then your beta 3 adrenal receptors are found in adipose tissue, right? Then the other neurotransmitters, it's dopamine. I'm sure people talk about dopamine, serotonin as your happy hormones. So dopamine is also a catecholamine. Remember, I said there's D1 and D2 when I was doing my mnemonic. And when we did that mnemonic, we said D1 was basically going to be G stimulatory, then D2 is going to be G inhibitory. But also we said the receptors are D1 to D5. So the first one and the last one are similar. So those are both G stimulatory. Then the middle three, they're going to be G inhibitory. So those reduce cyclic AMP. And then those that are G stimulatory, the metabotropic receptors allow an increase in cyclic AMP. Hence, you get your protein kinase A, then you get your phosphorylation, right? These dopaminergic neurons are found in several regions of the brain. The most important one for us being your uh, and for your nigrostriatal pathways, which are involved in your basal nuclei in terms of function. But you also find dopamine in the limbic system, in the pituitary. Then you also find it in the cardiovascular system, though less described. But basically, you need to remember dopamine with regards to your Niagara striatal pathway, as well as Parkinsonism, Parkinson's, right? Then serotonin is your 5-HT. It's also going to be found in the brainstem. Synthesis-wise, it comes from tryptophan, which is one of your essential amino acids in biochemistry, right? Um, in terms of its deactivation or degradation, it's also degraded by monoamine oxidase. It's also one of the neurotransmitters that will have a function, or rather, a pharmacologic function in psychiatry, right? So you then get selective serotonin, whatever receptor blockers and the likes, right? Receptor wise, well, there are about 7 classes, but I remember your 5-HT2A, they mediate platelet aggregation. Everything else, it's just there in Ganong, but I never found a way to remember that. But your 5-HT2A were responsible for platelet aggregation as well as smooth muscle contraction. Then you can find the receptors on both presynaptic and postsynaptic, right? Then in terms of pharmacology, sumatriptan is an agonist for those 5-HT receptors, which we can use to treat your migraine, right? Then also serotonin is linked to vomiting. So you can use ondansetron. I'm sure those who are in clinical work may or may not have prescribed this before. So it's an antagonist that can be used to treat nausea and vomiting, right? Then in terms of psychiatry, you get tricyclic antidepressants, which inhibit those receptors. So some of them are selective, some of them are non-selective. The selective ones, which you can use to treat depression, the classic example is fluoxetine. Then you can also get your non-selective um, uh, reuptake inhibitors. And the bad thing with these would be that some of them actually have effects on the heart, um, because they also affect your what do you call this? Your other catecholamines like norepinephrine, right? Then histamine, we talked about H1 and H2 receptors. So H1, the metabotropic ones are in the respiratory tract. Then H2, they are in your gut. So H1 receptors, they work via GQ. So they activate phospholipase C, then activate protein kinase C. H2 receptors, if you think about how we release acid from a parietal cell, and think about why we need to use histamine antagonists and in the treatment of that, it's because of the H2 receptors that we find in the gut. So these, they increase cyclic AMP, right? So I just want you to remember that histamine is one of the main, or rather, or it's less talked about as a neurotransmitter, but it's one of the main neurotransmitters. It works in arousal, it is a sexual function, it works with pain thresholds, works in the respiratory tract, in the abdominal tract, specifically for your parietal cells to release um your acid. Then substance P, it's a polypeptide. So this is one of the large neurotransmitters in terms of the classification that we started with. So this one mediates at the first synapse in the pathway for pain transmission in the dorsal horns of the spinal cord. So substance P is important in terms of pain regulation, right? Then you also then find other neurotransmitters, which are your opioids, and these are endogenous, right? So they can function as neurotransmitters. So you have enkephalins, endorphins. Um, these are your endogenous opioids. They work almost the same way. They bind to opioid receptors. So there's kappa and mu. then also the delta, which are also G protein coupled receptors. Right? So these allow for hyperpolarization when you're looking at the mu receptor because it increases potassium conductance. Then the delta and the kappa, they are going to close the calcium channels, and they also allow for that. So they inhibit your action potentials, right? So this is basically my last slide, which is showing